Our next speaker is Dr. Morrison. Dr. Morrison is a pediatric endocrinologist and associate professor with the Department of Pediatrics at McMaster University. She's also the co-director of Metabolism and Childhood Obesity Research Program at McMaster University and is clinically active in pediatric weight management and pediatric lipid clinics at McMaster. Her research is centered upon the etiology, consequences, and treatment of obesity and lipid disorders in children, and her work is supported by the Heart&Stroke Foundation of Canada, the Canadian Institutes of Health Research, and the Ontario Ministry of Health.
Good morning, everybody. Thank you very much to the organizers for having me come and chat with you today. We're going to turn things a little bit for this next talk because obviously I'm going to be talking about kids and not adults. And I'm also going to move away from talking about treatment of obesity to trying to address where are we at from a prevention perspective. I don't have any conflicts of interest, and so my objectives really are to just remind you about the current prevalence of childhood obesity in Canada and the long-term health consequences related to that, but also to understand what do we know right now, what does the evidence tell us about the prevention of obesity in the childhood age group. And I hope that you'll be able to utilize this knowledge that you acquire on how we can assist families in implementing lifestyle practices to change children's behaviors, and then talk a little bit about where we're going. So before I start to talk about obesity in the pediatric age group, the little reminder that we don't have a single cutoff for BMI. I still have kids that aren't referred until the BMI is 25, and you can see from this graph that a BMI of 25 for a 7-year-old is way outside of normal. And so it's important that you're thinking about percentiles, and that's what this graphic shows you. This is the new World Health Association growth curves that are recommended by most organizations in Canada. And I wanted to emphasize to you, though, that the only part of the growth curve that's considered normal is the very light pink part in the middle. So once you get into the slightly darker pink, you're into the overweight range, and then there's obesity, and then you see the very dark pink, which is severe obesity, something increasing in Canadian children, and that's usually who I see in clinic. So we're coming a little bit late in terms of when we see our patients. I'm going to talk a little bit about prevalence. So this was my old slide 12 years ago or so, and the first time we measured kids after a 25-year period was in 2004, and everybody went, uh-oh, we're in trouble here. We've got about a 3-fold increase in obesity that has happened over the time that we haven't been measuring our children. We were asking them to self-report their weights, but we weren't measuring them. So that's the bad news. It was certainly concerning to all of us, but we have continued to weigh our children since then, and there is some good news. And the good news really is that, as you'll see, 2004, 2009, 2011, there certainly is not continuing acceleration in the prevalence of obesity amongst Canadian children, and that is reassuring news. The not so reassuring news is coming from the United States and a number of other countries around the world to show us that severe obesity is in fact continuing to increase in kids. So although the numbers are not higher, the extent of obesity is unfortunately higher. Well, many of you have seen the adult slide that talks about all the health outcomes that are related to obesity. Unfortunately, the world looks exactly the same when you're a child in terms of the risks, the health outcome challenges that are present. We focused largely on cardiometabolic health, and you'll see the reasons for that in a few moments, but you need to be aware that obviously there are many other body systems that are impacted adversely. This is some data to to speak to the issue with respect to severe obesity in children. This was published last year in the New England Journal, and it now looked at different levels of, so overweight and different classifications of obesity in the childhood age group. And what you can see is that the prevalence of any of the cardiometabolic risk factors is higher amongst those who are more severely obese, with levels of high triglycerides, sort of about 25%, 1 in 4. High blood pressure is about 1 in 10 of children with severe obesity. So not terrible numbers. The challenge is that when you put those together, about 30 to 50% of children with obesity have multiple CV risk factors. So the prevalence of metabolic syndrome is in the 30 to 50% range for young people with obesity, particularly after the age of 10, where most of the work's been done. Well, why should we be concerned about that in kids? This is some old data now that looked at a longitudinal follow-up study and looked at BMI and cardiovascular risk factors, so metabolic syndrome, if you will, in adolescents, and showed that there's a 14-fold increased risk of having a coronary event or clinically significant angina before the age of 50. And people were a little concerned about this data. The numbers seemed very large, but really the number of individuals with events, given the young age, was relatively low. However, we had a very interesting study published almost 5 years ago now, and this is in men only, so that's the downside of the study. It is based in Israeli army recruits, and they looked at all of the individuals when they were 17, measured their BMI, and then followed them prospectively with very good measures for both diabetes and for coronary atherosclerosis. And their definition of coronary atherosclerosis was actually based on coronary angiography, so what we would consider to be a very good outcome, not just on a sort of cardiovascular risk factors per se. And what they showed was not great news. Because if I'm going to walk you through this, I want you to start on the left-hand side. This is looking at the relative risk of having coronary atherosclerosis in individuals based on their BMI when they were teenagers. So not on their BMI when they measured them in their 40s. If you look at the left, it shows that the individuals with the highest decile, so from the 90th to 100th percentile BMI as teenagers, had an almost 8-fold increased prevalence of coronary atherosclerosis. And then they said, well, okay, but we need to look at what's the influence of family history, and that didn't budge things very much. And we should also look at cardiovascular risk factors, because obviously those are important, and when they corrected for the adult cardiovascular risk factors, you'll see that the hazard ratio was still 5. And when they looked at diabetes, and they fully corrected, including the adult BMI, the prevalence of diabetes was exactly the same, irrespective of what their BMI was as an adolescent. So what does that tell you? That tells you that for diabetes, you can treat and prevent diabetes by treating in adulthood. Unfortunately, for coronary atherosclerosis, the same is not true. You'll see that even when you correct for the adult BMI, individuals who were in the top 10 percentile for BMI as teenagers had an almost 7-fold increased risk of having coronary atherosclerosis. So that tells me two things. It tells me that as a pediatrician, I really should be managing my patients earlier. And secondly, it tells me that prevention is really something that we all have to be focusing on, as challenging as it may be. So I talked a little bit about cardiometabolic health, and I just wanted to remind all of you that the patients that I see do not come to me because they're worried that they're going to have a heart attack. they mostly come because they don't feel very good about themselves. And so I want you to be aware that, of course, it's not all children with obesity, but a very high proportion of children with obesity have issues with respect to low self-esteem and mood and psychosocial challenges. And this is a graphic that looked at the prevalence, at the self-reported health-related quality of life in kids. And you'll note that as you go from left to right, you'll see progressively increased extent of obesity, that there is a gradually declining health-related quality of life. And this has been shown now in multiple studies in the pediatric population, such that children with obesity rate their quality of life as fairly similar to children undergoing cancer chemotherapy. Something that's very sobering for all of us. Okay, so when I talk about treatment, we heard a lot about lifestyle modification, and really in the pediatric age group, it's no different. We're focusing on 4 key lifestyle behaviors, very much utilizing family-based behavioral therapy on a background of mental health therapy. But I'm not here to talk to you about treatment. And treatment, I put this slide in so that I could remind you that the prevention of obesity is a very different thing from the treatment of obesity. In order to prevent something, you need to understand what are the causes, what are the things that lead to it. And I'm going to take you through some of what we know about that. And you've heard already today about the massive changes that we've had in our environment. And this is an enlightening, I guess, obesity causation systems map, which would kind of put anybody off if you had to address each of those boxes. And I'm going to walk through it with you to try and emphasize where we need to do our focus. So at the very core is energy balance, energy intake versus energy expenditure. I've highlighted physical activity. Of course, you all burn energy doing other things, and Dr. Wharton talked about brown fat, and we're all kind of enthusiastic that maybe someday we'll turn our brown fat on, or as kids we won't lose it, and that's going to help us burn energy without having to do much. But right now we're not there, so we really talk about physical activity as the main modifiable energy expenditure side. And on the energy, so that got messed up a bit, but on the intake side, we're looking at food intake. Of course, this big blue area in the bottom is a critical one. This is what makes us different. It's why some people gain weight and other people don't, even though they appear to eat the same or have the same energy output. It is also why some people's appetites are much higher than others, and is also why when we lose weight, our body is very good at protecting our previous weight. But there's a whole lot of this map that we haven't covered yet, and that relates to the environment that we're all living in. So the activity environment, your food environment, including food production and availability, and most importantly, both at the individual level and at the societal level, the psychology or the underpinning differences in energy balance. So it's not an easy task to try and address all of those when you're thinking about how we're going to be preventing childhood obesity. And I'm going to make it a little bit more difficult. I'm a pediatrician, so the vast majority of life, of course, happens before you turn 18. But we have come to understand that we really do need to think about the stage of the life course of the child in terms of the potential windows for opportunity, if you will. This graphic is also to show us that adults have a fairly significant impact on children. And the direct impact from the adult to the fetus is, of course, through the mother, but it's not just all on moms. We as adults have impacts on the children in our lives at multiple life stages, from infancy and even through adolescence, although some days we don't believe that. And that's true as parents, it's true as healthcare providers, and it's true as community members. And I hope that that's something that you'll take home with you today. What about the fetal exposures? Well, we've come to learn quite a bit, actually, in terms of what are the exposures in fetal life that increase the risk of obesity in childhood. And the most consistent ones are those indicated here. Both low birth weight and high birth weight predict increased cardiometabolic health problems throughout childhood. Maternal obesity and maternal diabetes also increase the risk of diabetes in the offspring, more so than paternal obesity or diabetes would. And that's particularly true, of course, if the diabetes occurred while the mom was pregnant as opposed to subsequently. Moving into infancy, we know that infant feeding choices has an impact. Breastfeeding appears to be protective to childhood obesity. We don't really know why. Some have thought, oh, it's just a reflection of the general healthy approach to living that breastfeeding moms have, but others suggest that it may be that the baby actually becomes used to more variety in their taste, as well as learning to develop their own satiety responses, recognizing their own hunger signals, which is less true when they're fed with a bottle. We also know that very rapid early postnatal growth predicts obesity, and I'm talking about sort of over the first 1 to 2 years of age. And interestingly, the most consistent finding in longitudinal studies for childhood obesity predictors is children reported to have poor sleep as infants or as toddlers appear to have it appears to be an increased risk factor for obesity. So all of those are important for you to consider. These ones will not surprise any of you who have asked about nutrition in your pediatric patients. Certainly, these are some of the commonest nutritional problems associated with obesity: high sugar drink consumption, large portion sizes, lack of understanding what a proper portion size is, and low fruits and vegetable intakes are really 3 of the key behaviors that we identify on a daily basis. And this is from the Canadian report on how well we're doing with physical activity, and that is not so well. I didn't put the numbers up there, but we're trying to encourage children to have at least an hour of physical activity daily, and there are very few children who are meeting that requirement. That's not new, and actually we're getting a tiny bit better than we were 5 to 10 years ago. So I think perhaps this is an area where we're moving a little bit, and this is an area where we're moving in the wrong direction. So sedentary behavior, sedentary activities, screen time largely, are certainly problematic. I now struggle to get a clear history from most of my patients as to how much time they spend in front of a screen, because they can't answer that. Their answer is, well, like all day. And I think it's when we have our phones, we've got our screens with us, our children are just the same. This was sobering data that came out of the guideline this year. The current recommendation is that under 2, they should have no screen time and an hour a day maximum for the 2 to 4-year-olds. And about 15% of Canadian children are meeting that guideline. And the average number of hours in front of a screen for 3 to 4-year-olds is 7.5 hours, which blew me away, I have to be honest with you. And it's because it's become something that parents are utilizing on a daily basis with their children. The older group, about a quarter of 5 to 17-year-olds are having less than 2 hours of screen time a day, and you'll see the average numbers there, and that's pretty consistent with what I hear in clinic. Okay, so in that world, how are we doing with childhood obesity prevention interventions? Are we doing a good job? Well, we had an update in 2015 that I was part of, and I'm saying that because I'm going to tell you what I didn't like about it. But it was sort of at that time, last year, was a meta-analysis looking at all of the data in the literature of randomized trials trying to prevent childhood obesity. we identified 90 studies, and you'll see that they called it relevant to primary care, but that was only because didn't mean that the interventions had to happen in primary care. Their school-based interventions were also part of that. And they really wanted to know about BMI. And they found 90 studies, as I mentioned, but they're not really obesity prevention studies. Because if you wanted to do an obesity prevention study, you would take all of the normal weight children and you would apply your intervention, and then you would follow them for the long term to identify what prevalence of obesity was in the two groups. And of course would be very challenging to do, but so that hasn't been done, but it is important for you to recognize when you're thinking about outcomes. We're so used to looking at obesity outcome literature that we expect that the BMI should go down, right? That's what we're wanting to see as a positive outcome. Anyway, most of these have happened in the school environment, and certainly 14 out of the 16 studies that have shown positive impact on BMI have been in schools. Now, this is a very long list here, and of course you don't need to read each of the lines, but you do need to look in that little red box and see that while it was significant, there was a very, very tiny decline in BMI. But remember that we very poor data in terms of prevalence of obesity. Let's go back to our map. Where were we focused? Well, we focused mostly on the individual. So we focused on the family members in some of the studies, on the kids, and a little bit on the school environment in some of these studies. Are there no community-based interventions? Well, there are community-based interventions, but they're really much further behind than these individually focused ones. And this was one of the first ones that sort of showed some efficacy, Shape Up Somerville, also from Massachusetts. And I've got the slide on the left because this is actually Shape Up Somerville City on the Move. If you look at the person delivering this address, it was the mayor. And I think one of the key learnings from this was that champions within the community identified that they needed to do a broad community-based intervention. They have shown some short-term efficacy, although their longer-term efficacy we haven't seen as much of recently. The one positive thing in terms of efficacy, though, is that the changes in the community engagement appears to be sustainable in that circumstance. Many of you will have heard here in Ontario that the provincial government was going to drop obesity by 5%, I think, and that was the Healthy Kids Challenge. Those have been rolled out across the province in several communities, many of them linked to EPOD Canada, and they are trying to really continue community-based interventions. I'm looking forward to seeing the outcome data that hopefully will be coming, because with all of these programs, the critical piece is being able to evaluate both the short-term and long-term outcomes. Well, you all may wonder, okay, so what has that got to do with me? I'm sitting as a physician, I'm in my office. How is this impact? How should I be impacting this? And I will say that you do have a role as parents and grandparents, and a role as community leaders in voicing and in being part of broader environmental approaches. But there are some recommendations for you specifically in terms of dealing with your families. And I'm going to briefly go through what the current guidelines are. The Canadian Task Force on Preventive Health Care recently, last year, published new guidelines on prevention of obesity based upon the meta-analysis that I presented to you, and they strongly encourage that physicians and healthcare providers of all stripes do encourage growth monitoring and plotting of BMI in the pediatric age group. They also, and it may seem obvious to you, but it is one of the key challenges. I see very many children referred to me with long gaps where heights and weights and BMI certainly have not been measured, and it's important not to look at height and weight only, but at BMI. The Canadian Pediatric Society and the American Academy of Pediatrics also recommend targeting key behaviors in children, and in particular, the American Academy of Pediatrics has emphasized using a longitudinal, developmentally appropriate, and a life course-based approach. So what does that mean? And on what evidence are they basing this? They've based the evidence largely on changes in behavior. Although I presented BMI data to you, there is good evidence, actually, that working with families can help them to change their behaviors. The family-based approach needs, first of all, to be focused on anticipatory guidance. I talked to you a little bit earlier on who are the families who that's a child who we would be predicting to develop obesity and the health outcomes, adverse health outcomes with it. And so thinking about that group is important. And as I mentioned, monitoring BMI from age of 2 on. The key behaviors are the 4 that I spoke to when we talk about treatment. And this is to remind you to think about low-hanging fruits. The one that I really think is perhaps the easiest one to discourage families from is sugared drink intake. And essentially what you're trying to do is encourage your families to modify their environments, their home environments, to make these the choices of more healthy approaches easier ones. Sleep is sometimes one that's forgotten, and one I would certainly encourage you to discuss with families, especially those with children and adolescents with their devices with them as they go to bed. So in summary, we have had stabilization in the prevalence of obesity in Canada. We are still very concerned about the health outcomes that will be coming from the third of Canadian children that are now overweight or obese. And there is, although I didn't have time to present a great deal of evidence, there is evidence that primary care interventions can impact family behaviors, that parents are sometimes willing to make changes for their family that they may not make for themselves, and most importantly, that anticipatory guidance is important, not just for the person who's sitting in front of you who looks like they're overweight or obese. We as physicians sometimes make an assumption that we know exactly what their nutritional and physical activity are based upon the way they look to us. And it's really important that you don't make that assumption, but rather that you ask those questions as you provide that guidance. And thank you very much.